Mr. Parker.
The question of the persistence with the $7 co-payment came up in both of your speeches. I wondered if you could try to explain why the government is so persistent. Is this purely a matter of ideology, neoliberal agenda, making sure that everything in life gets subject to the price mechanism? Or is it something to do with funding health research? And if so, what does that say about the current arrangements for funding health research, that we need this supplement to the system that's already run through the National Health and Medical Research Council?
Good question. I don't think it's about funding health research. I think it was, I don't know that they really thought about this before they were elected, but obviously they couldn't give up the opportunity. But to me, the co-payment is about destroying Medicare and privatising the health system. Are they doing it just for ideological reasons? I don't think they understand healthcare, because as John Dwyer pointed out, it's going to cause much increase in costs and a lot of inequity. I don't think they're doing it to get money for medical research, because the $20 billion wasn't going to go to medical research anyway. It was just the interest when they put that in the bank, which is a couple of $100 million, I think. They weren't going to put the whole 20 billion into research. But it was a nice carrot. They thought, oh, people will, it sweetened the deal. You'll lose Medicare, but you'll get research. But I still think, because of the persistence, and because of what we found in ICAC in New South Wales, and because in the past, I remember one of the health maintenance groups in the United States, I forget the name, being very close in one of the health minister's office. I think transparency is very important, very important. I'd still rather have the Royal Commission. We're having Royal Commissions now into unions and Julia Gillard and BATS, but all of those seem payback and for political reasons, and what are we going to get out of it? Whereas a Royal Commission into healthcare would seem something very productive, and a lot of positive would come out of that for the health system.
I do believe that the Abbott government is driven by ideology. If you look at the rhetoric, it's always, we've inherited the most terrible mess from Labor. We cannot continue to spend money at the rate we're spending it. We have to rein in the expenses. Someone's got to have the courage to do it. And Australians, you've got to come with us, and you're going to have to pay more, because we can't go on like this or we'll be bankrupt. Every economist in the world points to the luxurious situation of our economy.
Right, absolutely right.
And the fact that there's absolutely no reason for panic. There is no budget emergency. We are the envy of the other OECD countries, and that we can certainly need to tackle waste. But of course, what I think is getting under Australians' core is this ideology, which is potent from the Liberal government, is inconsistent. How can you be saying that when you have a parental paid leave scheme of what they're talking about? When the Abbott government is talking to us about the poorer Australians having to put their hands in their pocket for so many things, when somebody who can't find a job is gets $0 for 6 months. When you look at the protection of the big end of town, yes, there's an ideology there that they keep spouting about having to save the money and we've all got to bear the burden. But we're still one of the lowest tax countries in the world, and the government, as Hockey demonstrated beautifully with his car analogy, has no idea of the difference between a progressive tax and a regressive tax. And that, to me, I think that the Australians, I've never seen Australians in general so upset about one thing, the unfairness of this budget.
Just quickly, I just want to add one thing. The first thing that Mr. Hockey did when he got into power as Treasurer was to reverse Labor's limits on the fringe benefit tax for cars, for professionals or for anyone, the limit of $2 million on superannuation benefits for the very rich, and doctors could only claim $2,000 back on their educational visit to Europe, whatever. The first thing Mr. Hockey did, as I remember, was reverse all those. Reverse them. I mean, if there's a budget emergency, now a doctor can go on a $30,000 cruise with his wife and his kids, all on the taxpayer, because they give a few educationals on the boat. So if you're talking ideology, it certainly does seem ideological.
I just have a question about whether there are any moves to, in Australia, have the New Zealand model of Pharmac. Coming from a New Zealand background where I was a general practitioner in New Zealand, we were constantly hammered by Pharmac and we couldn't prescribe various things, so it was all very restricted. That very effectively reduced the drug bill in New Zealand. And do you think there are moves that model might be adopted in Australia to rein in our hideous drug budget? Save some money.
What's Pharmac?
Pharmac was an organisation which did deals with drug companies whereby they wouldn't buy an expensive drug, and if they did buy an expensive drug, they had to supply a certain amount of... Yeah, so it basically was a lobby group that hammered the drug companies and didn't allow them to flog $40 tablets for cholesterol control. They would only be able to buy cheap ones. So it meant that the drug companies, the big pharma companies, left New Zealand. So there were some downsides because they couldn't sell their drugs there because Pharmac said, no, we're not buying your drug. So, but it got our drug budget down tremendously. So it would be drugs are a huge cost in the health system. So it would be a really good thing if Australia had a similar sort of lobby group. And they're very powerful in New Zealand.
Okay, thank you.
There's no such plan in Australia at the moment. We, as Colin was saying, we actually pay far more for our drugs than the same drugs into Canada and New Zealand and many other countries. We've done a very poor job of negotiating that. It's becoming increasingly difficult to get really valuable drugs, new drugs, on the PBS. And one of the things I like about the New Zealand primary care system is that they have in-house drug educators who educate the doctors working in the primary care practice about the cost effectiveness of different drugs and the evidence base for those different drugs. And that also has had a positive effect on drug expenditure in the right way, because the doctors are using the drugs that are available more wisely. There's a lot of things which are low-hanging fruit, if you like, that we prescribe that don't really do that much. But it is a scandal that we pay so much more for drugs, and even some of the generic drugs are only $1 or $2 cheaper than the original drug. We're not getting the sort of benefits that other countries get, where the drugs become extremely cheap. So no, we don't have that system here. Our PBS is rising rapidly. We've got to use it more intelligently, but basically we should be doing a much better job of negotiating with the pharmaceutical companies on the basic cost.
Well, it's coming up for renewal. I think the generic one, I think it was up for renewal. I don't know what happened, but there was the potential to save a lot of money if the government did argue for much better prices. And it reminds me of when one of the health ministers interfered in the PBAC and got Celebrex on over the PBAC, under their guard, and we ended up paying a lot more for it. And then that minister ended up, when he left, getting a job for that with that drug company, as I recall it. As I recall it. So again, I think if we do get a Royal Commission, I think the price of drugs... But the reason I took the microphone was really to say what someone told me, reminded me, is that with the free trade agreement that's coming up, I think that's going to be the biggest threat. Because at the moment we use the pharmaceutical benefit scheme, if we used it correctly, which I'm not sure we are, but we'd get much better bargaining power, which then flows on to the rest of the South Pacific. And if the TP, I'm not an expert, but if that comes through, the government might not be able to have a stronger bargaining position as we did.
Charlie Bradley. I'd like to ask a question, but I'm having difficulty sort of focusing it. It's about the building up of infrastructure that is needed when you bring about the sorts of reforms that you've been speaking about. That in the first place, the education of the GPs would be changed, but more particularly the sort of community-based arrangements would involve professional development and change. And so part of the investment that we've heard about tonight would require investment itself. And if you can comment upon that generally.
Well, you're quite right. And what we can see around the world and what we should be doing here, I think I can best describe by talking about a journey. If I absolutely am determined that next summer I want to go to Paris for holiday, my destination is perfectly clear. I've been to London, I want to go to Paris. That's clearly my destination. In the analogy, a destination is a healthcare system focused on prevention and infrastructure. Now, to get to Paris, I've got to do a whole lot of things. I've got to save some money, I've got to work out how I'm going to pay for the tickets, there'll be bumps along the road, etc. But other countries have decided that their destination has to be integrated primary care in a system that's less, and they've got to supply the infrastructure for it, and it's going to take a journey. If you look at New Zealand, it took them 10 years to get to where they've got at the moment. It was bottom-up modelling, health professionals urging the government to do it, population being won over and coming on board. 85% of New Zealanders are enrolled in a primary healthcare organisation. 85% of the GPs have moved away from fee-for-service. They're much happier. They've got team-based medicine with a major emphasis on prevention. The longest journey, however, starts with the first step, and the frustration in Australia is that we can't get political leadership to accept a destination. If you think of the 4-year political cycle, 3-year political cycle, it's a curse in this area, because the politicians want instant reward. They're like children, that they need to have something that they know the next election will be very popular. Whereas for this transition and to build the infrastructure and to slowly reorganise the money so that it flows more into primary care, because we're going to be saving money in hospital care, it can't happen overnight. But any responsible government that's not politically lazy needs to be doing more long-term planning and to look at the way other countries over a decade have completely transformed their healthcare system. Yes, of course it can't be done, and you can't, like in so many endeavours, you've got to spend some money to save some money. But we can, that's one of the things I'm frustrated about with all this talk about the fact we're bankrupt and we can't afford it. We can easily afford to invest for the savings that will flow.
I just wanted to put to you a proposal, which is actually a variation of one that was brought up a couple of weeks ago by, of all people, Jeremy Samet of the Centre of Independent Studies, a group that's not normally mentioned in these hallowed halls. But yeah, basically it was the idea of a lifetime medical savings account. That was a standalone idea in replacement of the Medicare levy I think he was talking about, as you expect from a Conservative commentator. I've been sort of thinking about the idea of a hybrid model where you keep a Medicare levy but also have a medical savings account, and the idea being that it's an incentive for people to keep themselves healthy, because obviously if they don't dip into that account then they get to keep it. And if you give them incentives similar to superannuation in terms of tax concessions, it can be very lucrative with compound interest. But the idea I had was actually dedicating that money to be used for medical research, which I think is a much more attractive and politically saleable idea than the $7 co-payment, and this idea of building up $20 billion eventually and getting $1 billion of that to be used annually. So I just wanted to see if you have thought about this or come across this, and what you might think might be the positives and negatives, if you have thought about it.
I hadn't thought about it, but look, I think this idea of trying to take better care of yourself is very important, but we've got to be careful to avoid a victim-blaming approach, especially the lower income, the more difficult it becomes to have access to time, to exercise and blah, blah, blah. The most important factor to me is access to a concerned, interested GP that has got your back, the problem is particularly with men. I think all of us here in this room, all the men will know that we're scared shitless of going to the doctor or getting bad news, and so we tend to avoid. So the first, and that's why this co-payment is such a stupid idea, because it just brings even more disincentive. Yeah. But certainly someone who's interested is one of the most important factors in you taking good lifestyle measures, and someone who's going to see you semi-regularly, be interested, and that there's not a lot of disincentive from going to see them.
Well, I think the Abbott government's very interested in that sort of approach. They have the Reform Commission put as its last recommendation to government, but they did talk about a Medicare Select project where the government gets out of the healthcare system altogether, gives every Australian a medical account, puts $4,000 into bank account and says, go look after yourself, go. Now, they actually tried this in the Netherlands with disastrous results, and the cost of healthcare spiraled up. And the real weakness with the problem is that I might be able to afford to keep that reserve for my healthcare in the bank. But so many Australians are living with $10 in the bank between paychecks. By the time they pay the childcare, it's a bit like superannuation. You know, they simply cannot afford to have be building up reserves when they're young and they're not, and that they might be able to spend on their healthcare later on. And the thing about inequity is that in the long run, it's so expensive for all of us because unless we say that someone who gets sick is not going to get care because they can't pay for it themselves. Having a large group of the population of chronic illness costs all of us a lot of money. So I think that model, and if you're interested, there's an economist called Ian Macaulay at New Canberra University who's written extensively about this and why this is not a good idea for Australia. And in an ideal world, if we're all wealthy and we're able to afford to keep this reserve, it might have some merit. But in the real world, it has no merit.
I do think that politics in the South should be cancelled because it only makes us upset. The third thing, before I come to question, is yes, the Royal Commission might achieve something, but I think, you know, like we have these, John Howard introduced these tests for migrants, and they had to show they understood Australia. Well, I think we should have a test for politicians. I asked them, what do you understand by the Enlightenment? Write two sentences on what you understand by evidence-based decision-making. And can you, a couple of questions on basic statistics, like, you know, what's the meaning of a mean and standard error and stuff. My serious question is, quite rightly, John, you talked about community care and so on. 25 years ago, a guy called Peter Elliott, I remember, gave a talk on ILF care. Could have been 30 years ago. There are more agencies, actors in the community, of course, involved than just in the health. And one of my pet hates is the Grocery Council. And today there was an announcement that a private NGO or whatever, a non-profit mob, was launching its own rating systems for food. And they said, we're sick and tired of waiting for the government to do something. The minister said, oh well, we'll release the grading system online when we're ready. 2 months ago she said she'd release it in August. The Grocery Council said, the fact that we've been made some progress showing we're willing to work. The Grocery Council, like the Chamber of Commerce and Industry, are people preventing any progress towards a better society. How could we integrate all of that?
Obviously, if Gotti's Royal Commission, one of the things that'd be looked at is how come Fiona Nash's turned down the release of a guide that would help Australians understand good food from bad food, when her chief of staff actually was a representative, his wife was a representative of the food industry. So I mean, there's all sorts of things like that. But look, the major thrust of your question, and what's really important, is that we have in the community, we have diverse agencies and things that can do things for people, but what are Australians are most frustrated by? It's a lack of coordination, integration. They get sent, you go and see your doctor and he says, right, I want you to have an x-ray, you make an appointment in 2 weeks and come back and see me, and take another 2 weeks, then he says, right, you better go and see the physio. The whole situation with older people at home is that the community nursing service is disconnected from the patient's GP. The advantage of the integrated primary care model with the team practice model is that all of the resources needed to focus on an individual patient's needs are there in the one practice, and the person in the practice who is most advantageous to the needs of the patient at that time is the case manager. It's a completely different concept than what we have at the moment. People love it, it's brilliant, it's cost effective, and the health outcomes are infinitely better. That should be my Paris, that's the journey that we need to go on. It will take us 10 years to get there, but we're not going to get there without that first step, and that first step requires political commitment.
In particular, I'd like to thank Dr. Costa for plugging this important rally on Saturday. There's a few of us here from the Save Medicare Committee, and we've been working very strongly all this year with a whole series of rallies, and we've handed out, I think, 5,000 or 10,000 of these leaflets around the place, including up on the North Shore. I just wanted to mention that the campaign against the co-payment, it's really important because it's actually not just a question of the medical system. It's actually the centrepiece of the campaign against the Abbott's budget, because it's the most clear-cut issue which everyone can relate to. Everyone can relate to Medicare. It doesn't matter which sector of the community. So that's why the importance of it is. I just want to mention that one of the key elements in the discussion on Saturday is going to be the other question which people have raised, is this privatisation by this government and the state government of everything that moves or doesn't move. And there's going to be two of our speakers on Saturday. One is from the CPSU, because they're going to sell off the Medicare payment system, and this is related to the co-payment. It is setting up part of the infrastructure for the collection of the co-payment, is to sell off Medicare from the public service, from Centrelink, to the private sector. And the second thing is the privatisation of the hospital system here in New South Wales, and one of the big campaigns is against the setting up of a private hospital on Northern Beaches. The Nurses Union will be talking about that. So I just wanted to ask our speakers just for a further comment on this whole pervasive privatisation of the medical system in every aspect: Medicare, hospitals, the influx of the selling off of Medibank Private, and the Centrelink payment systems. Thank you.
Well, the sale of Medicare Private is estimated to give the government $4 to $5 billion. It's a one-off payment. They say to help them reduce the deficit, and we've heard plenty of discussion tonight about the fact that we need to keep profitable enterprises available to us to have a steady stream of cash. But the really important issue is that if the private health insurers are allowed to extend our private health insurance coverage from hospital care to primary care, it is inevitable that they will want more for their privately insured patients to keep those patients out of hospital, because that's the reason they would want to get into this business. We know that Medibank tells us that 6% of the people that they insure gobble up 40% of the total payments to hospitals, because they're repeatedly going into hospital and they're very sick. So they have an interest, obviously, in avoiding this hospitalisation. But if they are allowed to cover us for our private care and to do deals with GPs, that they will pay them more to see a privately insured patient, you will have an absolutely two-tier system, as Con was saying, which should be an anathema to Australians. In other words, if you go to your GP and the receptionist divides you between those who've got private health insurance and those that don't, And there's better services for those that have private health, better services for those that have private health insurance. That should be totally unacceptable in Australia. That is taking us down the American path and would be disaster. And it would all cost us a fortune because the people who get the lesser service are the ones that are going to end up with chronic diseases costing us. It's unfair and it's got to be stopped.
Yeah, and also it'll be so much worse for the people that we talked about before in the nursing home. If they're not getting the care now, imagine what chance they have when the GPs have seen all their private patients. Can I just remind you that probably a lot of you here are paying when you go to the GP. I think GPs are charging $60 or $70 or $130 if you're a long consultation. I know when my daughter went, it was $70 plus $180 for the mental care plan. That was $250 and only $36 rebated on Medicare of all that money. But the important thing is that the bulk billing, if it continues, even if you aren't bulk billed, sets a ceiling for the general practice doctors anyway, prices. If they get rid of bulk billing, then the barometer is not the 36, it becomes the AMA rate of 72 or 130, and then quickly the market will go up from there. So this is why bulk billing is critical, that it be, you know, not be gotten rid of. Otherwise, the AMA, the doctors, it'll be like going to a specialist, $300, $350. Many Australians can't afford that. Yeah, many of the elderly in the nursing homes don't, and specialists won't go to the nursing homes anyway. So healthcare quickly gets out of reach.
I'd like to just make one comment on this that no one's touched on yet, and neither has the government, but it's in my area of risk and investment, and that is where that $7 is going to go. I've looked at companies, I'm thinking of one in particular, it's publicly listed, out of Adelaide, that was trying to find a cure for cancer. They've almost gone broke. This is going to piss money, pardon my language, I apologize for that, it's going to piss money down the toilet. Finding these kind of products that are going to save the world or be good is very, very risky, especially if it's done by doctors, because they have a problem with risk. And I'm not knocking you guys, but I'm just saying to you, this is very risky. They could put that money elsewhere, which has already been suggested by them. Anyway, I got that off my chest. I just want to thank the speakers tonight, and please show your appreciation for them, please.